Good evening to all. So phacoemulsification in the posterior segment. So phaco in the posterior segment, or rather phacofragmentation, would be required when the lens falls posteriorly into the vitreous. So posteriorly dislocated lens or lens matter can occur following a cataract surgery, though it's an uncommon complication. Every cataract surgeon would have at least one case of posteriorly dislocated lens or lens matter. If not managed promptly, that can lead to other severe complications that can threaten vision. It can also happen after blunt trauma. Blunt trauma can cause the whole lens to dislocate posteriorly into the vitreous, and other genetic or systemic conditions that can cause zonula weakness. So, retained lens material following a PC rent can be anything from small cortical fragment to an entire nucleus. So, why do we need to be wary of this, or why do we need to fix this? Because the lens capsule, the intact lens capsule, has an immunologic function, and when it is breached, that can lead to phacoanaphylaxis. So that leads to non-specific inflammation with cystoid macular edema, posterior synechiae, uveitis, glaucoma, and macular edema. So what are the indications of nucleus for nucleus removal? There are two lines of thought. One line of thought says that lens fragments, if it's more than 25% or more than 2 mm in size, that only needs removal, or if there is any presence of inflammation or uncontrolled IOP or associated RD or retinal tear or any other complications. The second line of thought is that all dislocated nucleus fragments, irrespective of size, must be removed because small nuclear fragments may trigger severe complications like uveitis, glaucoma, corneal edema, or RD. Now, generally speaking, small amounts of retained cortical material often can be followed up, as they can be absorbed without the need for surgery. They can be treated with topical anti-inflammatory drops and close follow-up for the development of CME or any other complication. Larger pieces, more than 2 mm in diameter, almost always require surgical removal. So when should it be operated? The timing of vitreous surgery. Early intervention is obviously helpful, lower incidence of glaucoma, better visual outcome. And the referral is urgent but not an emergency. It's not necessary to be removed on the same day. It depends on the convenience and the availability of the VR surgeon at the same day, at the same OT, and also depends on the corneal clarity. Most of these cases, cornea may not be clear immediately following the surgery, so you can always delay the case for 1 or 2 weeks for the cornea to get clearer, but it should not be delayed over 3 weeks as that may lead to other complications. So the recommended approach for the removal of posteriorly for posterior dislocated lens matter is PPV with removal of the lens fragments with or without ultrasonic emulsification with the fragmentome. Most eyes with retained lens fragments generally do well after vitrectomy, with the majority recovering with good vision. So it's no more dreaded complication if managed well and if communicated well with the patient. The technique for the removal of the nucleus depends on its grade. Soft lenses and cortical fragments may require a cutter only for removal. Dense nuclear fragments would require fragmentome. So phacofragmentome has it's 20 gauge and it has a larger luminal diameter. It's nearly 4 times than a 25 gauge vitrector. So that enhances the flow and flowability of the nuclear material. So this is a picture of fragmentome. There are a few differences between the phacoprobe and fragmentome. Phacoprobe inside sleeve is 21 to 23 gauge, whereas fragmentome is 20 gauge. It does not have a sleeve, it's a bare metallic tip. Fragmentome has a separate infusion line and phacoprobe has irrigation through the sleeve. Fragmentome uses only longitudinal ultrasound. Phacoprobe has longitudinal, torsional, or transverse ultrasound type. Because of the sleeve and irrigation through the sleeve, there is constant irrigation and cooling for the phacoprobe. But fragmentome has this thermal risk because there is no sleeve. So I'll go to one video. So this case was taken 1 week after the cataract surgery. There was nucleus drop. IOL was not put. Suture, the wound was sutured. So it's a 23 gauge vitrectomy system. First, we do a vitrectomy, core vitrectomy. A complete vitrectomy is necessary. These small cortical fragments can be easily removed with a cutter, as you can see here. You can see more than half or nearly half of the lens is dropped. So you clear the vitreous all around the lens before introducing the fragmentome, because fragmentome does not cut the vitreous. It only um, uh, it only has it only aspirates vitreous. So, and this is so hard a nucleus that it cannot be removed with cutter. So one of the 23 gauge cannulas is removed, and the sclerotomy wound is enlarged with with an MVR, so that the fragmentome can be easily introduced. So fragmentome is 20 gauge, and now it's getting introduced. The sclerotomy should be a little bit leaky, so that the risk of burn to the sclerotomy is less. So fragmentome, you should make sure that the lens is free of vitreous all around. So once you introduce the fragmentome, you first apply suction, and then you catch hold of the lens and bring it to the mid-vitreous cavity, and then apply ultrasound. The idea is to divide the nucleus into smaller bits, is to fragment the nucleus to divide into the smaller bit. Here you can see the light pipe can be used as a second instrument. It can be used as a chopper to help in dividing the nucleus into smaller pieces. So once it is divided into smaller pieces, it is easy for the fragmentome to emulsify the smaller bits. Always apply ultrasound after it is occluded in the mid-vitreous cavity. You can always inject a bubble of PFCl in the posterior pole to protect the disc and macula from any inadvertent injury. The PVD induction can be done before phacofragmentation or even after. Both are acceptable. Here, once it is divided into small pieces, it can be easily eaten with fragmentome. You should make sure that the IOP is made a little bit higher, 30 to 40 millimeters of mercury, because of the mismatch of 20 gauge and 23 gauge. IOP is usually set above 30 millimeters of mercury, and 50% ultrasound power is initiated. So once the nucleus has been removed with the fragmentome, the other remnant cortical matter would be easily removed with cutter. So after the fragmentation is over, the cutter is reintroduced, and here the PVD is being induced. PVD induction can be done even after, even before the fragmentation. And at the end, make sure that you see the periphery indented, that there are no breaks, and make sure that there are no remnant lens fragments in the periphery as well. So this was another case in which the lens was removed with the cutter itself. This was a vitrectomized eye, and the patient had lens touch, and the cataract progressed rapidly, and he was planned for cataract surgery, and the day before this lens drop happened. So you can see this fluffy cortical matter can be removed with the cutter, and even the nucleus in this case was easily removed with the cutter. Fragmentome was not needed in this case because it was not very hard. We have one more video. This is the whole nucleus. It's the same thing as fragmentome. Yeah. So these are few points. So whenever there is a PCR and lens drop, do an anterior vitrectomy and put IOL if possible, and suture the wound always, and start topical steroids, anti-glaucoma medication, and hypertonic saline, and do phacofrag as soon as the cornea is clear for surgery. And PFCL always reduces trauma to the macula and disc, and periphery should always be checked for iatrogenic break. And phacofragmentation has a satisfying outcome if managed properly. Thank you.
Doctor.